applicable in a lot of different research areas. And when I first heard about it, as a methods person, I'm learning a new method. I was really excited. And I saw a lot of the applications that I thought it would be useful for. I've given this talk, versions of this talk, as I said many times. And so I'm going to speed through a few things. Okay, and also, can you advance me? Yeah. Oh. One more back. Oh, back.
Go back.
Wrong way.
Wrong way.
I'm sorry.
We said no.
Oh, I see it. I see it down here. I see it.
Yeah.
Sorry, I've never used this. It just started making me use this.
Yeah, I should get rid of those animations there. Just
Let's see. Okay. All right.
okay.
Now, there.
Okay. So I wanted to show this slide because I don't have an outline for this talk. It's an experiential exercise, and I'm going to demonstrate 3 applications of this process. And the process itself has 3 components, and those components are brainstorming, organizing the brainstorm material, and then applying it or using it. So please ask questions as they come up. Okay, so the reason I don't have an outline and the reason we do this experientially is because it's hard to describe what this process is by just sort of talking about it. If you want more advanced, thank you. And the reason it's hard to describe is because it starts out with the explanation that group concept mapping the first step is conceptualization through structured elicitation. And I say that, like, what does that mean, right? So that's what we're going to do is unpack that. Before we do that, I want to do a quick example in case the idea of conceptualization isn't clear to people. And the example I'm going to use is patient experience. So you can advance the animation. So we kind of know that there's a patient experience measure that is pretty widely used, and in fact, on which some payment decisions are made, which is the CAPS survey. Advance, good, thank you. But conceptualization is the step before something is operationalized or put into an actual tangible measurement. And it's the idea of conceptualizing the thing itself, right? What is patient experience? So that's what, when we talk about conceptualization, that's what I mean. The conceptualization of most of our measures, including the CAPS, happened around some experts sitting around and making some decisions about what the phenomenon is, right? So what is this thing? What I call these generally phenomenon or concepts. And that's what happened with CAPS. Can you advance me? That also happens to be the case for most of the major measures that we're used to, that we're familiar with, like the SF-36, where you can see the description of the original development was a bunch of internists, family physicians, cardiologists, psychiatrists, psychologists, sat around and decided what constituted health-related quality of life, right? So I don't think we often think enough about that step, but who decided what this thing is? Who gets to define what this phenomenon really is? And the group concept mapping process, that's why one of the reasons I was so excited about it, you can advance me, initially was because now we have guidance, right, about the use of patient-reported outcome measures for labeling claims and reimbursement decisions. And the FDA says in this report, if you're interested in looking at it, they say the conceptualization process must include the stakeholders in whom the phenomenon is assumed to operate. So that was like a really big thing that was nice. Because historically, that's sort of the point I'm making, that was never done. It was always the experts who got to decide what constituted the phenomenon, who got to sort of map out the conceptual space. So that's what I mean when I say conceptualization, that's that process. Structured elicitation means nothing more than brainstorming, I think. In response to a specific prompt. Go on. Engaging the individuals who know that space best. And that is the key thing. Rather than just a bunch of experts getting to decide what constitutes patient experience or what constitutes health-related quality of life. The process, group concept mapping, then allows for visualization of that space. Excuse me, so you can advance me. And the visualization occurs by getting the same people who helped you conceptualize the space to sort responses into conceptually related groups. Go ahead and advance me. So if you are at all familiar with the CAPS, there's the revision to the CAPS, the many revisions that have happened. There are sub-scales, right, or subsets of items, and those were decided based on mapping items to the IOM domains. And so There, go ahead. There is an assumption, oh, there's a whole bunch of animations on here, go ahead, pressing the button. There is an assumption that the space of patient experience or patient satisfaction has some structural features, go ahead. And that assumption is manifest in these subscales or subsets of items, right? 3 of which are the experience with the providers, the experience with their doctors and nurses questions separately, satisfaction with the discharge process, with the facilities, go ahead. The physical environment, there's many. Pain control is a new one. And I think there's one more that recently a subset of questions around care transitions has been added. But the point I'm trying to make is often when we conceive of some conceptual space, then we also sort of imagine or assume that it has some structure, right? Some structure. And we historically, the way it's always done is that structure is imposed from the top down. So group concept mapping, in addition to allowing us to conceptualize the space from the bottom up, also allows us to figure out what its structure is from the bottom up without appealing to any expert consensus. Okay, carry on. Okay, so those are the first 2 things that sort of I wanted to walk through using the cats. So that we're kind of clear around what conceptualization means and what kind of like the structure of a conceptual space might look like. And then there are some other things that can be done with group concept mapping, which we're going to look at the end. I think I said everything I wanted to say. Okay, so having said all that, any questions about any of that? A lot of new words. Okay, so so this is our first exercise. So go ahead and advance this one. To do this exercise, you have to imagine that you are a patient who has had a recent emergency department visit. And so that is that's the field of experts that we want to ask, right, about the phenomenon that we're interested in here. So this springs from a study that I worked with on an ED physician colleague of mine who was frustrated seeing patients in the ED and sending them home and telling them, we don't know what's wrong with you, right? And, she was developing this whole theory about around uncertainty and how it feels on the provider side and how it feels on the patient side and how it contributes to subsequent visits. And there's no measurement tool for this phenomenon, and no one had conceptualized the phenomenon. So we undertook this process where we asked patients with a recent visit this question. So this is the prompt. When I said it's brainstorming in response to a focus prompt, this is the prompt that we used. So I want you guys to imagine that you are the people who have had a recent ED visit and read this prompt, and we're going to brainstorm. So please don't advance right now. So just imagine your own responses to this question as a person with a recent visit. When experiencing symptoms, people might go to the ED when they feel uncertain about what?
The diagnosis,
Right, what's my diagnosis?
severity,
How serious is it?
what's going to happen next.
What's going to happen, right?
Can this make me better? Is there something that can make me better?
Right, am I going to get better?
Can I make someone else worse?
Right, right, am I endangering someone at home? It's an interesting process, right? Just a simple focus prompt that yields answers which are concise, that they're not quite qualitative data, right? We don't code this data in the traditional way, but it is. Am I dying? Honestly, am I dying?
Yeah.
Absolutely.
Yeah.
Okay, so, right, we have some chat. Okay, so we can move it forward and I'll show you some of the responses. We already did that. That we got. These are actually representative responses from this particular project. And you'll see yours reflected here, and then you'll see, right, some that we, what we say we're going to do when we do this process is we try to conceptualize to saturation. So that requires more than one session, right? So that you can get a sense of when new ideas stop emerging. Right, can I afford to miss work? Is it okay? Oh, go back. Well, I'm sorry. I should have. Can you go back? There you go. Oh, yeah, that's fine. These are them. Does your regular doctor know how to treat what's wrong with you, right? Patients are often uncertain about whether or not their primary care doctor has the expertise to treat something that lands them in the ED. There's some stuff around the bill, the wait time, right? Are these life threatening?
Yeah.
Okay, so I'm afraid that you've advanced 2 slides. Can you try going back a couple? Sorry.
Yeah, so are you seeing the ones with all the answers?
Yeah, but there's 2 versions of those. Yeah,
Oh,
there's
I
2
gotcha.
slides that are
Okay.
exactly the same.
Let me see.
Okay, no, we're in the right one. Okay, that's fine.
Okay.
So go forward and then we'll go forward. Okay, so this is the first process, which is this conceptualization through structured elicitation, which is a pretty easy research process to implement. You know, recruit, bring the folks in. I don't call them focus groups. I call them brainstorming sessions. Let's have a brainstorming session. If you are doing it in a rigorous manner, then you have at least one so that you can try to get some sense of when new ideas stop emerging. What have we accomplished here with our pretty simple research approach? Go ahead. We used structured elicitation to conceptualize this space. Go ahead. Keep going. We elicited a group-based conceptualization of this phenomenon, right? We sort of fleshed out this space. We collected data in a very efficient way. This beats interviews, right? One-on-one interviews over and over and over again, and then all that thematic coding, right, which takes a long time. So it is an efficient process. So that's it. That's the process of elicitation, conceptualization through structured elicitation. Go ahead and advance. What could we do with this information now that we've got it? So the next step in the group concept mapping process is with the same informants, with the same participants that you're using, you ask them to sort the ideas into piles, and the instructions literally just say, sort these into piles that make sense to you. So you can advance us one. So here's the subset that you saw before. Take a look at them and see if it seems like it would be easy. These are literally like virtual note cards, right? Each idea is printed out on a virtual note card. Would it be easy to sort these into piles that make sense?
Yeah, there's like stuff about bills. Like severity, time. Time's also here.
Yeah. Right. Concept sorting is something that people just do naturally, right? We sort stuff all the time. That's kind of how our brains are wired. We love to sort stuff into, you know, this goes together and this goes together. So we just literally ask folks, and they're seeing their words and their ideas reflected back to them, right? And everyone else as who participated. Sort these into piles that make sense to you. Okay, so go ahead and advance.
Do you do this as a group? Is it like you have 8 people in the room and all 8 people have to come to a consensus, or everybody does
everyone does their own sorting
individually? Okay.
And there has to be a little bit of a lag between the brainstorming and then the sorting, because there is some processing of what comes out of brainstorming, so that everything is about the same length and phrased generally the same way, you know, and then we process that data and then we set, you can do it in person, but it's much easier. Well, we'll talk a little bit about logistics at the end. Yeah.
Usually the same group of people that are in that brainstorming group
Absolutely, yeah, you're
versus
trying to get the same group of people, although, I mean, from a sampling perspective, right, if you sampled out of the same population, then theoretically, right, you could just, you know, they didn't happen to be there for conceptualization, they happened to be there for sorting, or vice versa with you. Okay, so, you know, just out of the ideas that I threw up there for us to consider, we did see some pretty clear conceptual piles emerge, right, and that is a pretty cool thing. So not only have we mapped this conceptual space and maybe a saturation if we're doing a good job, but now we've also kind of visualized the structure of that space. And we did it all from the bottom up, right? Using the participants, the respondents who are the experts in that field, who you know, understand the lived experience of that phenomenon. Okay, advance this. Okay, so what could we do with this information? So concept mapping is an old technique that was used to elicit learners' understanding of complex things. And it wasn't until I saw my first talk on this, I remembered my first undergrad stats class. Someone came in and had us like sort statistical ideas into piles. And then they came back at the end of the semester and did it again because they wanted to see the semester of statistics learning helped learners move their understanding of the field from beginner, you know, to a more advanced level. And that there's still a lot of that going on. So if you search for concept mapping, you'll find a lot of that. But as researchers who are interested in group-based conceptualization, what can we do with the data that we just got? Go ahead. We are going to apply some statistical techniques to every individual sort. So everyone does have their own sort. And we're going to produce a map, and we're going to use a couple of techniques. But I mean, the statistics probably don't matter because they're under the hood, right? Like you get some software that does this for you. But generally speaking, I think there's two animations on here. Multidimensional scaling and cluster analysis are used. Go ahead. To produce a point map. So the point map represents each circle is an individual statement, and the distance of the statements to each other represents how often they tend to get sorted together. So this literally is the representation of the conceptual space. So you can see like 168 people tended to think went together, but 121 never went together, right? This is what the multidimensional scaling does. And then cluster analysis tries to partition this space in the most efficient way possible. So go ahead and advance.
So those are all the cards.
All the statements, yeah, so we have about 100 responses, yeah. And so this was the cluster solution that came out of this study, this project. And these, yeah.
I was gonna say, so some of them kind of like disappear, like we no longer see.
Right, so I have a reference here to the papers that go with this, so this is a little, yeah, this is a little simplified, just so I can get it all in the slides, yeah. And go ahead and advance, actually, I think that's next. So we published several papers out of this project. One was just the conceptualization process and results, right? We said, look, we identified the domains of uncertainty, right? And that's publishable data, I think, and it's interesting data in the city you don't get in any other way, right? This is a really novel way to say, what does some, presumably, I mean, it would be, of course, very cool if you found something novel to conceptualize, but also we really just need to go back and reconceptualize a whole bunch of stuff, right? From, using patient and, perspectives that aren't currently contained in there. So just to make the point that the conceptualization itself is interesting, but what do we really feel like we want to do with this data now that we have it? Go ahead. Done. We want to create a measurement tool, right? We want to be able to quantify. So we did indeed do that. Go ahead.
Can I interrupt you for just a second? I'm so sorry. Cluster analysis,
Mhm.
you have to tell it how many clusters you,
Yes, that's right. So, yeah.
which is true for everything that you're going to tell us about scale development. So factoring requires you to tell it how many factors you want. So at some level, you have, as the researcher, you're sort of making a decision about, actually, we think there's some structure that goes to this based on our assessment of how well they write. Like you can't totally rely on math to give you everything in those cases.
Well, that's true. The multidimensional scaling is what it is. The point map
Yep.
emerges,
Yeah,
right? But the cluster analysis can be subjective, but there are some numeric indices that can be used to assess the goodness of the fit of different cluster solutions. And we take, if it's ambiguous, right, we take it back to the stakeholders and ask them to help us interpret it. But what it really comes down to is just making sure that you don't go in with all 100 statements. So the first few years I did this, I was like, we're going to represent everything that people said because, I want this to be sort of ecologically valid, and what they said is what they said. And then I came to realize as time went on, questions that don't directly answer the prompt should be discarded. And that always gives a better, kind of a more cohesive solution. Especially for a measurement device. But I feel like, what I want to do, right, is compare factor analytic solutions, right, post hoc factor analytic solutions to the stuff that comes out of the cluster analysis of just the raw data, because factor analytic solutions are often really awful. So I think that's a fun project that hasn't been done yet. So we created a scale for this phenomenon of uncertainty around making the decision to make an emergency department visit. So you can go ahead. And that's a pretty cool way to develop a measure, right? And it's a way that's not often used, and it's a way that allows stakeholder input, maybe in a more structured way than a focus group or individual interviews would provide, I think. And I think because there is some objectivity in terms of as I said, indices of goodness of fit around the cluster solution. They don't, we, we don't necessarily go straight in and say, here's our scale with all its subscales based on just the cluster solution. We would administer the whole scale and do the post hoc factor analyses, right? And see the extent to which they support the structure that we thought we saw a priori. But in any case, right, we've developed a scale using authentic stakeholder input.
Just to say, part of your factor solution at the end will be dependent on how well your items represent the construct that you hoped they would, right? So you develop an uncertainty around time or something.
Symptom severity,
Symptom severity,
yeah.
right? And you then develop 10 items. Well, maybe item 10 was terrible. And so
Mhm.
that one couldn't load to that, but maybe it wasn't because your factor solution was wrong. Maybe it's because the item was bad.
Right.
Right, so there's other ways.
Right, we still use, regular sort of scale development and refinement techniques, but this is the raw data that goes into that, yeah. Okay, so this is the second paper that came out, which was the scale development and preliminary validation of this scale. This was when? 2018. And then, so now what do you want to do is a little bit of sort of, well, I'm going to do air quotes, validity testing, right? So we then used it to try to predict, right, subsequent ED visits in a sample of people who had had an ED visit. You can advance one. So that's this paper here. So the 3 papers came out of this project. And the scale is in use. I get a lot of emails from people saying, I want to use it. Can I remove these items or do this or that around it? And I think uncertainty as a phenomenon is understudied and, could probably use some more probing around uncertainty post-hospital discharge, right? Uncertainty about, the many things that bring patients back to the hospital when they're discharged, which of course also has pretty significant financial implications. So, all right, so that was the uncertainty project, and that shows the processes of conceptualization and the sort of structural or organizational piece specific for measure development. Time, just fine. But I want to point out that many phenomena that are very difficult to think about or conceive of, how would you even start to conceptualize that measurement space, right? In my opinion, this is kind of the only technique. I mean, interviews are okay. I don't talk about it in this talk, but I had a PCORI methods grant from 2015 to 2018, which they funded us in the methods portfolio just to compare this process to interviews. For efficiency, for comprehensiveness, for saturation, right? And we did find that it is cheaper and faster, but also that the participants find it more engaging, right? They like it better somehow, probably because they're all together, right? We get everyone together and do the group brainstorming. They, bouncing ideas off each other. They're learning from each other. And yeah, so there's like the references at the end have the couple of papers that came out of the sort of the comparison of interviews to concept mapping. Since then, I have a doctoral student who just graduated who did structural racism in healthcare. That's a tough one, right? We got physicians, providers, I think nurse level and up, hospital executives, billers, coders, right? Administrative people to talk about, and that, remember it's a specific prompt. And so just in terms of implementation, again, it's the creation and refinement of that prompt is incredibly important, right? To make sure you're asking the right question. And I don't want to misrepresent it. If I have it in the notes, I remember the exact prompt for that project. It was something like, what processes or procedures do you see in your workspace, right, that might indicate that racism accounts for non-white patients receiving worse care, something like that. But, we've worked very hard on trying to decide what that prompt would be to elicit structural racism in healthcare. I have an ongoing PCORI right now where we're looking at barriers to research participation in patients recently discharged from the ICU. The PCORI project, the content area we focused on was type 2 diabetes management. And so we asked diabetes patients, what outcomes are they trying to optimize when they seek treatment, right? So the whole, in keeping with, of course, PCORI funding, right? Like what are the patient important outcomes or patient-centered outcomes. I have a doctoral student right now doing, and I love this so much because social determinants of health is really hot, right? And we want to know what are the social determinants of health, like as a conceptual space, as a measurement space. That's a really hard one. Do they differ by disease state, right? The doctoral student is doing social determinants of health that are relative to child asthma exacerbations. And she's doing a really specific, like at school. So these are like school-based health center providers and talking about asthma exacerbations that happen at school. But then the question is sort of about the social and environmental conditions in the child's lives that might contribute to poor asthma management. All kinds of, anything you can imagine, right? You can try to conceptualize it using this process.
When you asked folks, the study you did at the beginning, about the efficiency and things like that, did you also ask about these sensitive topics and how they felt in discussing sensitive topics with conceptual mapping versus one-on-one interviews?
I don't recall. We developed a survey for them to ask them about the processes. I don't know if we talked about sensitive topics in particular, but my doctoral student who did the structural racism project, she has a talk that she gives separately where she talks specifically about how she thinks that this technique is appropriate for vulnerable and historically marginalized populations. Whether that's, specific in any more than it would be just beyond that, sometimes when there's something wrong with you or you're sick or you have a diagnosis, when you're sitting in a room with a bunch of other people who had had the same experience, that there might be something empowering about that. There are a couple of references. You can, I think, advance one. Two references that talk about problems that we've had with this process. And those references are here. The very first project I ever worked on was a program planning and evaluation application, which we're going to talk about now. But it was with formerly homeless women with serious mental illness, and they were using the technique. This is how I learned about it. A colleague of mine, she was using the technique to try to optimize like treatment strategies for substance use in that setting. This technique actually arose from a program planning setting, and so you'll see the application is pretty obvious. So this was the very first project I did and published when I was at the primary care practice, and so this was the prompt we used, which was, and we asked providers and staff like at the practice and then also patients separately. What are some ways that patients can be involved in order to improve the care we provide? Turns out, since this was my first project, this is a bad prompt, right? This is a double-barreled prompt because it's how can patients be involved, but also how can we improve our care? So that's a bad prompt. And we got answers in both buckets, and that makes sorting difficult. But this was the first one. So I wanted to show it to you because it illustrates the other things that this technique can do. So go ahead and advance. Here's a few representative responses. Again, the question, the prompt was, how can patients be involved in order to improve the care we provide? And it's first project, about 100 responses. I don't know. I always get about 100 responses. I don't know. Go ahead and yeah, advanced one. So this was the cluster map that we got. You can see the domains were things like enhanced community resources, improved technology, stuff around access and navigation, patient empowerment, communication. Go ahead and advance. But here's something that we haven't talked about yet. So the third step, if it's needed, is to do some other analyses with the data. And the analyses that are generally suggested, go ahead. Or to have participants rate the ideas. So from the program planning or evaluation perspective, we asked, how can we, give us some ideas for improving our care, right? Involving patients to improve care. So these are supposed to be actionable things. We're really going to do these, right? We took these to our patient and family advisory council. So the next step that we did then was to ask people to rate the ideas. Go ahead. And the common dimensions are, these are just example responses again, so you keep going. What generally is recommended is for this sort of an application in particular, you ask people, go ahead, how feasible is it to implement this idea and how much of an impact would it have if we implemented it? So go ahead. But then what you can do is you can visualize those ratings at the individual idea level or at the cluster level, right? So how this is like average feasibility and impact of the technology, all the ideas in the technology cluster. Go ahead. Other cool things you can do though is look across groups of stakeholders. So here's the patient, what patients thought was feasible and what the providers thought was feasible, right? And you can take a look at areas of overlap, and that is a really interesting thing. So we always collect, you can only do 2x2 comparisons, and so we always collect, you know, if there's a demographic that makes sense to ask about differences, then that's interesting information to collect. So that's what everyone thought empowering patient productivity and self-care was feasible, which just is bizarre to me, but yeah, so go ahead.
So interesting.
Here's the same thing for the what would have the greatest impact.
I love that providers were like, yeah, this is impactful, but not feasible.
Right.
Right.
And then one more, and then you can visualize these things in what are called go zone diagrams, where you can see the things that everyone thought, right, that the patients and providers all agreed was feasible. This is a patient versus provider. If you go to the next one, I think it's a impact go zone. What I don't have shown here is the impact and feasibility go zone, right? Because there's like a quadrant that shows what people rated as most impactful and most feasible. So this is the original development of this technique was for this application exactly. Okay, go ahead. So this is a paper I published a long time ago talking specifically about this project, but also what I was trying to do was kind of get, you know, the people in the space that I was in, which was academic primary care, to think about using this as an engagement technique, right? Because I do continue to think that it's very engaging. And this was around 2016, around the time that the hospital systems were, it's saying everyone has to have a patient advisory council, right? But I've been to so many patient and family advisory councils where there's 6 physicians and 2 patients or family members, right? I mean, they're not engaged. They're not really empowered to tell you what they think you should be doing, right? So I just love this technique for, you know, so many different applications. Go ahead. Okay, so just a few quick notes then about implementation and software, et cetera. So you can do this by hand. Do the brainstorming by hand, process the ideas, feed them back to people on literal note cards, right, at a table, have them sort, right? You bring the sorts in, you enter them into the software yourself. If you know how to do the statistical modeling, you could do it in, you know, you enter everyone's individual sorts in on different Excel sheets, right? And whatever. I've never done it, except I did it in R, but that's also all under the hood. But anyway, you can do it by hand. Those are the 2 papers I mentioned, right? Patient experience and challenges, right? Those are some of the lessons learned that we took away. And then also this was the concept mapping about the criminally helpless women.
Is there sort of functionally a number of people you need to do the sort to make it alive?
You can click through. I think I have an FAQ that addresses that. Yeah, just keep clicking until we. So I just wanted to show you. One more. Mary Kane and William Trogan is really he's the social scientist. So I don't know if any of you have seen, like, Trogan published a text a long time ago called like the Handbook of Social Research Methods. Like he's a big guy in the field of research methods in general. He was at Cornell. He's still alive, but long since retired. And Mary Kane, who was his collaborator, they sort of invented this technique. And so many of the early publications are Trogan and Kane. And they also started this company called Concept Systems, and they sell this software. Oh, sorry, that's enough. Can you click? Oh, here's my animations are messed up. Can you click one?
Sorry, forward or back?
I think the animations are bad. So the license and the software is not bad. Software lets you set up anonymous email accounts for everyone, right? To invite them to come to tell, you know, and then it also gives you a virtual desktop for sorting, right? So that you can mail people a login and they get a virtual desktop with all the cards and they literally pull them over and sort them into piles. It does all of the under the hood stuff, right? It lets you click through different cluster solutions and look at the statistics associated with them. And, you know, so it is I don't work for them, but I do like the software, but it's not cheap. I just pasted those in this morning. I think an individual project license for a nonprofit organization is about $2,000. For a for-profit organization, it's about $5,000. A full year unlimited license at a nonprofit is about 3,200. But that's a full year. So, you know, if anyone is going to be doing it, then you just get your college or department or whoever you work for to pay for the unlimited license for a year. There isn't an R package that does it. I have not used it. And this was from maybe 21 or so I don't know if it's been updated. I don't know what kind of functionality it has. The real benefit for using the concept systems and the group wisdom interface is probably the communication, right? You can email directly from there. You can keep track of the last time people logged in. You can even process remuneration through there. I remunerate. Okay, so now we'll just go to the FAQ. And this hopefully is, I think one more. Yeah, so it takes a few people in a room to do this because someone has to be recording responses while someone else is sort of facilitating the discussion. It takes a moderator who has a little bit of qualitative training to reframe to make sure that people are responding to the prompt. So I might say to you, are you saying then that one of the things people might be uncertain about when they make the decision is, you know, whatever it is, so that I keep people on track and get them responding to the prompt? The brainstorming, you know, really probably doesn't matter. I have a paper, I don't know if it's there. It's in the references. I published a paper shortly after this where I did kind of a statistical examination of saturation. How many sessions does it take to reach saturation? Because if you're really going to do a good job at it, you want some assurance that you reach saturation. For sorting, I'll tell you that better sorts are more important than many sorts. Some that and if you do this seriously, you set some rules for yourself in your protocol, right? So if a respondent has fewer than 3 piles, we're going to discard them. I'm not even going to look at what they said, right? Last time, I think the project that we're just wrapping up, which is the ICU project, I think someone had 1 pile for every statement. So there's some, you put some rules in, you say which are going to be discarded, because once you have passed that threshold and those people are in, if their sorts are nonsensical, right, or they don't really match what everyone else sort of thought of the structure of it, then it's difficult. Then you can get kind of a messy, a messy structure. But in many ways, depending on your application or why you're doing it, oftentimes the structural piece is not the most important part, right? The most important part is the elicitation and then the rating, right? And the rating is done at the individual idea level, so that even if your clusters are messy or overlapping, you can still, all of the ratings happen at the level of the individual item. So you have those anyway. I've experimented with, in the measure development space, trying to ask people something like, how central is this idea to the concept, right? So but that's a tough thing for people to think through when, we're eliciting about uncertainty related to making a decision to seek emergency care. And then, how central is this? So probably you don't want to ask your original, stakeholders that. But something like, how can we overcome barriers to research participation, right? Certainly, your respondents know the answer to that, right? They know how impactful or feasible that might be. So there's some nuance, obviously. Yeah, it's not easy. There is data processing. There are decisions about getting rid of things that didn't answer the prompt. It should be the same people at every step, but again, it depends on your purpose, right? Why you're doing it, what you needed out of it. I think I might have interrupted you. You were asking like a tech or a logistical question.
I don't think, was it me?
I wonder how many people, what's the minimum number to do the brainstorming? Like if you're doing 2 groups, do you need at least 5 people per group? Like it's hard.
There's no telling.
Okay.
It depends on.
Well, maybe a better question. How many is too many?
Well, it depends on your ability to manage a group. So in the first ones we had big groups of 18 or 20, but there were 5 of us in there. Right? There were, because we wanted to do it all in person, including the sorting. So they were at computers. And then at lunch, we did all the processing and then brought them back after lunch to do the sorting on the computer. So everyone had to be there at the same day. So we just had a big group with a lot of facilitators.
Okay.
But in the structural racism project, we collected most of that data during COVID.
Yeah.
And all of it online. So that's another thing that's nice about this is you can arrange these group brainstorming sessions through Zoom, right? And you have someone who's recording the ideas and a couple of facilitators. The whole thing can be done online. So that's nice. Yeah, so your ability to manage the room, if you're gonna try to establish saturation, then it depends on how many groups you can sequentially, schedule and get people in for it. But that's what I was gonna say. In the structural racism project, there was a hospital president, several physicians. We couldn't get them in at the same time. We brainstormed with 2 people. If we could get them scheduled, we brought them in. Yeah, that was it. And that's the crucial step, right? Is that because you're gonna know you've established saturation, and that's when you know you're done recruiting, right? That you're done. Then you try to get the people back for the next step. So I pay people a lot of money for this stuff because it's not easy to sort 100 ideas, is it? It takes a long time. And because I'm a Picori-centered researcher, and I believe in compensating people adequately for their time, right? I usually offer $150 for the brainstorming and another $150 for the sorting.
My other question is, I really love the sort of agnostic approach to starting this, but in a lot of spaces, there's actually a lot of theory that it pre-exists. So how do you think about sort of using theory on the front end to inform what some you're doing, or check what they've come up, what your participants come up with against existing theory? But how do you sort of marry those 2 things in a space that's not, totally devoid? We've never looked at it before.
Right.
That's pretty unusual. There's usually something out there.
I don't think you could, right? Because the nature of group-based conceptualization is such that you have to ask that, if you're interested in hospitals' quality of life, for example, right? You just have to ask, what are some factors that contribute to good quality of life for hospitalists? It doesn't matter how much literature is already out there, because you couldn't really ask the question any differently. But I will tell you, from my doctoral student who did the structural racism project, obviously I said, did you find anything new? The question is, did you find any domains of structural racism that weren't already in the literature, right? Given that the cluster solutions can differ, right, depending on specific statements being in or not being in, or the choice of 7 versus 8 clusters, and the cluster names. The software does a good job of trying to generate a name based on the content of the statements in that cluster, which is kind of interesting. But that's kind of arbitrary, right? So, I was just really asking her to match what she came up with to existing conceptual models of structural racism in healthcare, right? So, that from a academic perspective, I guess it's an interesting exercise to say, if you ask a different group of people, right, do you get, anything different from existing conceptual models?
Now, I was even thinking sort of, here's what we came up with. Like, you might at the very end of this, after you created your entire solution, say, here's what we came up with. Here's what a group 10 years ago came up with. Could you respond to both of these? Do you think that this one that we came up with represents what you've done? Like, do you think this represents what you've said in your experience? Do you look at these other 2? Do you think these represent your experience? Did we miss anything? Do you look at those things and think, oh, that one, that maybe needs to come over too? Like, there might be an opportunity to sort of bring back the final solution and compare it to other things and get perspectives on that.
That's a really nice idea. Yeah, the recommended step, if you look at the old group concept mapping literature, like Trocum's original stuff, as I said, was for program planning, is always a final meeting with everyone who participated, where you present the solution and you say, is this what you guys meant? Does this all make sense? Should we move statements around? Because you can move statements around by hand on the back end, maybe, which sort of gets at what you're saying.
Yeah.
But a couple of times I've done this, and I mean, just like really distinct clusters emerge, and there wasn't a lot of overlap or either. In the measure development context, you can always check that on the back end by administering the items, in fact, or analyzing them, right, to look at the structure piece. Yeah, so I think that's it. So go ahead, right on time, good. Yeah, that's it. So, yeah, thank you. Feel free to email me. There's all kinds of references on here.
Can I ask a question about the prompt? Because it seems like the key is the prompt.
Yes.
Because you can really go off track,
Mhm.
it seems like pretty easily. So who and what process do you use to like refine the prompt?
Mhm. If I'm working with a learner or a trainee, right, we'll always put together what we call like a research advisory council or committee, which if it's a doctoral student is the committee, but I make them bring in a stakeholder.
Okay,
If it's a fellow or resident who's doing a project, right, you just gotta have, but that doesn't even guarantee that that you're gonna get a good question. It wasn't until the end of that whole project that I was like, oh,
it's a double.
that's a difficult question. So that you pilot it over and over and over again, right? You pilot it. Is it gonna elicit the actual responses that represent that conceptual space? Do people understand it to mean what you thought it meant, right? So yeah, absolutely, you pilot it until you feel it's the right one. Sometimes people are disappointed. They start the process and then they realize I can only ask one question, right? You can only ask one question, yeah. This Barriers to Research Participation project, one of my co-Is, who's actually kind of senior to me, the project's about addressing barriers to research participation. And I was like, we can only either ask about barriers or ask about strategies to get people to participate, not both, right? Which was tough. Yeah, so we had to do them both. We elicited the barriers and then we
Two separate.
really two separate projects, yeah. Yeah, so that's one of the things about it that people find a little maybe unsatisfying is you can only answer one question. Yeah, you can only conceptualize one space at a time.
Are there certain topics or things that concept mapping really doesn't work for? It sounds like it's really good for like program development and new concepts or these kind of phenomenons that haven't really been talked about with stakeholders or those who it impacts with with lived experience. But are there things that you would recommend kind of staying with that just doesn't fit, or this methodology doesn't fit with?
My immediate thought was if it's a research area that's so new that we don't even know the right question to ask. We don't know if it's one phenomenon or two, right? Then you would probably start with a more, straightforward qualitative approach, right? Like, so for example, health-related quality of life. I don't think because of the way that health-related quality of life measurement space evolved, is it quality of life? Is it about health status? Like that got messed up in the beginning. And maybe some, clear qualitative work would have helped in the beginning. But again, if you can phrase a question, right? If you can come up with that focus prompt, then that tells me that you're ready. I mean, it's one conceptual space, right? If you're ready to conceive of one conceptual space, then you're ready to go. Yeah. Thanks.
Have there been any of these concept mapping projects with kids? Does this work?
Oh,
Okay,
that's
Obviously, we're all pediatric providers, so.
I peer reviewed a paper a couple of years ago that used this technique with young adult critical illness patients. They were literally end of life patients, and it was about optimizing care, like asking them what was important to them in their care. So you could find that paper, I'm sure. I don't do anything really with kids or adolescents, except I remember because I happily or not happily, so much concept mapping research gets sent to me.
Yeah.
For peer reviews that I know what people are doing. Yeah. And that was a particularly interesting project.
Young adults, meaning like 20s or young adults?
I think they were all below 18. I think they were children
Okay.
technically.
That's perfect, like,
Probably not, yeah.
Yeah, although now I'm remembering it was something like young adults with life limiting illnesses. So I don't remember exactly, but it would be easy to find. Do you think kids could participate in something like this? That's an interesting question.
Yeah,
I
like
think older.
I think adolescents should be
Older
like,
adolescents, yeah.
They do this in schools.
I feel like, right. Yeah.
School age
This is
kids.
definitely like a school type activity. I think they would probably, I wonder if more facilitators would be.
I think it would be more important to have a good, like, modern facilitator who works with that
Population,
population.
Explain what you do. So, yeah, this is a very selfish question. I do fire injury prevention research, which is why I asked about the sensitive topic.
Oh, yeah.
I am really interested in this type of thing to do some qualitative work around understanding violence impacted youth and families' experience in the healthcare system
Mm.
to help inform future hospital-based violence intervention programs. And so we are going to do a focus group with violence impacted youth and their parents over the summer. But eventually, Allie and I have been brainstorming, if this might be an interesting method to try to get some of the concept to then understand what a program might look like.
For program planning, right?
And I will also say that, in terms of someone asked about like sensitive topics or, you can you can do this in a completely hands-off manner if you want to, right? So you can email the brainstorming prompt from inside
And they
the
just type it?
software and they type in whatever they think, and then you aggregate all the data. So there is a way in which, often if it's a really sensitive topic, we say don't do a focus group, right? Do an individual
right.
interview, but sometimes that's still you there with that person, right? And if
Right.
you maybe feel like responding would be different if it were completely anonymous, right? Then you can still use this platform to brainstorm and sort. I also was thinking to the question about really young kids, if young kids can sort for sure. So even if you don't think they're the best informants to conceptualize the space, they can, it would be interesting to they can still sort, right, young people.
So like if the teens were the one who came up with the idea,
Yeah.
to do two different.
Younger
Keep it
kids
simple enough.
sort and keep it simple.
Yeah, the technique is really flexible and there's no guidance, like no one is out there telling you what you can and can't do, right? So like
Yeah.
any research project, if you can justify the decisions that you made along the way, right? If they make sense in the context of the question you're asking and the population you're working with, it's fine. It's not like there's anything.
Like
You
right.
can't do it, yeah, you can't do it right or wrong, yeah.
I feel like this is really good for your K, because it's like it's novel, right?
Yeah.
Because it probably hasn't been done.
Yeah.
And
I feel like there was some sort of mapping project for an HBIS, that I need to just look at again,
Yeah.
but I don't know if it was for youth.
And I think you made a point, like, maybe it's a sensitive topic, but if everyone has the same, like, some amount of shared, like, experience
Experience.
with that, then it's like, almost like,
Yeah.
maybe not cathartic, but like, they have that same
That's what we're doing with the focus group,
lived experience.
but we're doing like we're doing like 2 to 3
Mhm.
small groups and then doing a larger group of like the 8 of them, but they start in their small group to share their experience and then they report back into a larger group to try to help mitigate some of that. So,
Yeah.
I do wonder if this would be.
To those of you online, it's an hour, so thanks so much for coming and listening, and feel free to email me with questions or for a copy of the slides. I'm also happy to collaborate.
That's great.
Thank you so much for coming. I really appreciate it.
Thank you.
Thank you. I'm
That was
sorry
awesome.
I'm soring if I messed up your slide.
Thank you so much. I know that wasn't easy. I appreciate it.
Eric's like frozen. It is. Sarah, we're coming back to you soon.
I think it's really, so we've spoken about kind of my project and my K resubmission, I think went back, we didn't have quite enough time. I feel like if I had more time, I
Yeah, that's
probably
yeah.
potentially would have reworked potentially one of my aims, but I think you and I kind of came to as well that reviewers wanted me to get so many additional things out of my qualitative work that I couldn't just ask one question.
Yeah,
And
yeah,
so I felt stuck
yeah.
with, because for me, I do think it's the impactful, feasible, and the go, no go lineup between the patient and providers is like perfect for stuff that you and I do, Kristen, like, because there is often such a mismatch, I feel like, and I feel like we go so deep down these roads before we've actually matched those things that we're like going to a road to nowhere because we didn't take the time to like match these things in the beginning.
So, you can do parts of this, the elicitation of the ideas and then the rating of the ideas can be done. And you could just skip the sorting because that is the hardest part. It's the hardest part for participants. It's the hardest one to put parameters around deciding what to keep or not to keep. Sometimes the sorts are really messy and awful and you're like, well, I don't know what this means. But if it would be useful to get a list of ideas and then have them rated for impact and feasibility, sure, why not? Yeah. So for program planning, right, the example, one of the early examples I saw was someone was like, let's say I give your organization $1 million and you've got, 300 employees. Are you going to decide what to do with it, right? Like that's a very practical program planning kind of application of this.
That was kind of
What should we spend our money on?
Right,
That's an
exactly,
easy question.
Exactly.
Yeah.
That was that's our last question of the focus group is like the magic wand question.
Yeah.
Of like, you have unlimited resources, like what would a hospital violence intervention program?
Oh, that's a cool one, yeah.
And so that's what I was wondering if we could do that for that. And like, to your point, the reason we haven't gotten a NASHA here is because there's this huge tension about like what we need to do for the community and what the leadership feels like is feasible, whatever. And so I do feel like what's the?
And the go zones.
Yeah, the goes in. I
Those
think
are so
that would be
helpful.
beautiful to like show at a leadership, like at a board meeting.
I mean, yeah, those,
Boom.
not graphs, but yeah, just showing
Yeah,
like
those
where
are cool,
they
yeah.
mapped from like the provider to the patient.
Yeah.
Yes, that would be
Yes.
so
Yeah.
gorgeous.
Yeah.
Yeah. You may have just invited many more questions.
I like writing grants, it's one of my favorite things.
Oh my
Yeah.
gosh.
I don't, so. To keep kids safe, so we can be
Okay.
a power
That's-
move.
That's my boyfriend, so. You can hang up.
That is some cool support.
Yeah. That's so great.
That's so funny.
That's so